In recent years, there's been a great deal learned about pancreatic cysts. They used to be thought to be either just pseudocysts or cystic lesions that were not neoplasms, but we've learned now that there are a number of different kinds of pancreatic cysts, many of which are neoplastic, and the problem still remains of trying to diagnose the individual specific kind of cyst, because we like to know what its malignant potential is, and how to make that diagnosis. And then finally, how to treat it once we have the diagnosis made. In this case, we are going to discuss a man in his 70s who has an asymptomatic cyst. Many of these are now initially diagnosed accidentally, serendipitously, by imaging studies that are done for some other reason, such as an ultrasound of the kidney, and then a cystic lesion is seen in the pancreas. This man had his cyst first diagnosed 11 years ago. It was asymptomatic, it was small, and it was felt that it was safe to follow it. Over the next several years, the cyst remained really quite stable. One can see in this CT scan two different studies, one from 2005, one from 2007, in which the lesion basically is quite stable. It does not have the appearance of a pancreatic adenocarcinoma, which of course is really crucial in terms of differential diagnosis. As this was followed, additional studies were done. This is an MRI, which often is able to very clearly pinpoint not only the size of the lesion, but also its relation to the pancreatic duct, as one can see in this study. And one can also pick up smaller lesions that were not appreciated on the CT scan. In this case, there is an additional small 1 centimeter cyst closer to the head of the gland than the 4 centimeter or somewhat smaller than that lesion in the tail of the pancreas. MRI can further delineate the cystic component and the septations which really characterize many of these cystic lesions of the pancreas. But still, we don't know which exact kind of cystic lesion this is. We could get a fine needle aspiration, both for cytology and for fluid, if it can be obtained, which can help to pinpoint the diagnosis in much more specific terms. But still, for many of these, we really can't determine the exact cystic lesion in perhaps a third to a half of cases, which leaves the uncertainty about whether or not to continue to follow them or remove them with the question of malignancy lurking in the background. There is also the question of the anxiety of the patient who is worried about what this really could be and whether he or she wants to go on and have additional studies 6 months, a year later. Can the patient live with that? That's often a determining factor in what gets done. So in this case, we see over a period of years that the lesion stayed pretty stable on the small side, less than 3 centimeters, closer to 2 centimeters for much of the time that we've been following it. But in recent years, it's begun to grow. And this is characteristic of many of these lesions, and in particular, a serous cystadenoma, which is what this was presumed to be on the basis of the tests done. They often grow very slowly initially, and then at some point reach a critical size at which time in which they begin to grow. And in this case, in the last few years, the lesion had grown to over 4 centimeters, as you can see from this graph, over time. Now, the lesion was still asymptomatic at this point in time. The question is whether whether it will cause symptoms such as pancreatitis or pain, or whether it will impact or even obstruct an adjacent structure such as the portal vein. Once the portal vein gets involved, it can make the surgery much more difficult to remove the lesion. In this case, the decision was made because of the growth and because of the patient's anxiety about that growth to proceed with an operation. The next aspect, of course, is whether the patient is fit for an operation. He's in his 70s. Does he have other comorbidities, heart disease, kidney disease, or whatever that would preclude a safe operation? It was judged in this case that he was a fit candidate for the operation, did not have significant comorbidities to preclude it. So then the question is, what kind of operation? The lesion was in the tail of the pancreas, and the standard approach to that would be to do a distal pancreatectomy, or resection of the left side of the pancreas, with or without the spleen being taken along with it. Enucleation has not been a favored approach because of the prevalence or the risk of fistulas after enucleation, and also because the chance that there is an element of malignancy makes enucleation a less than desirable way to approach this. So then the question is spleen preserving or not. And in general, we try to save the spleen if we're not worried about an adenocarcinoma of the pancreas, because of the splenic function that is important in terms of postoperative post-splenectomy sepsis and so on. There are basically two ways to do a distal pancreatectomy. One can either dissect it off the vessels, preserving the splenic artery and vein going to the spleen, or take the splenic vessels, leaving the spleen to survive on the short gastrics to the stomach. That's an operation that we described perhaps 20 years ago, and it works in most cases because that collateral circulation along the short gastrics is sufficient to keep the spleen alive. There's also an advantage to doing it with taking the vessels, because if there is an element of malignancy, dissecting partially within the pancreatic parenchyma to take it off the vessels might risk leaving cancer behind. So in this case, the so-called Warsaw operation, or spleen-preserving resection of the vessels approach, was taken. This is the specimen. The transection margin is on the right as you're looking at it, and where the spleen was preserved is on the left. In the center, with the arrows, you see the multiseptated cystic lesion, and to the right, the smaller arrows show that 1 centimeter incidentally found lesion, which was not the reason for the operation, but which came with the distal pancreas. This is the main lesion, and this is the smaller lesion that came with it. The histology of this is that of a serous cystadenoma. You see the larger cyst to the right, and the characteristic of a serous cystadenoma is to have multiple small microcysts within the wall of the lesion, which are also easily visible here. And in addition, a characteristic most commonly found is a central scar, which actually can be seen on the scan, on a CT scan, in a substantial number of cases, and which can be considered diagnostic of this lesion. This is the higher power view, which shows the low cuboidal histology, and it's quite benign. The chance of a malignancy developing in this kind of lesion is extremely small. Basically, there have been about 6 or 7 cases in the world literature of a cancer arising in a serous cystadenoma, that is, a serous cystadenocarcinoma. So, to all intents and purposes, the fear of malignancy with this kind of cystic lesion, as in contrast to essentially the large majority of other variations, the fear of malignancy is inconsequential and not a reason for doing the operation. This is the other lesion. It is a unilocular cyst, which is characteristic of an intraductal papillary mucinous lesion. It does, in contrast to the serous cystadenoma, have a potential risk of malignancy. This is a side branch lesion which has a lower risk but which can be more aggressive when it turns malignant. As a general statement, this 1 centimeter lesion, almost without any nodules on the wall, has almost no risk of malignancy. Size matters, and the presence of nodules, or ultimately the presence of symptoms, none of which are characteristic here, and this by itself would not have been a reason for an operation. This is the histologic section here, which shows on the left the columnar mucinous epithelium lining it, but also in another segment some low cuboidal epithelium. And one of the characteristics of the IPMN, the intraductal papillary mucinous neoplasm, is that there can be variation of the lining epithelium in different parts of it. So in summary, the diagnosis here is a serous cystadenoma, a benign lesion to all intents and purposes, one which in most cases is found in an asymptomatic state, but which grows and which over time needs at least to have some degree of surveillance lest it grow beyond the size that would be acceptable. Also, these lesions, which occur more commonly in women, distributed throughout the pancreas, can be associated, it is believed, with a higher incidence of other GI cancers, so another reason for surveillance. And finally, it should be noted that the serous cystadenoma is a characteristic component of the von Hippel-Lindau syndrome, which is associated with lesions in other parts of the body, notably a pheochromocytoma, and therefore one at least has to raise the question of whether there is a genetic component to the serous cystadenoma in an individual case, even though that's only a small percentage of all of them. This patient had an uneventful recovery, and there has been on follow-up no evidence of further tumor development elsewhere.